I said that GCK mode appears to be quite frequent cause of gestational diabetes. There are some data suggesting that there may be as many as 10% women with gestational diabetes, which disease can be explained by GCK mutations. So again, when to think about GCK mode, about glucokinase mutations when you are dealing with women with gestational diabetes. Okay, think about it when you see persistently elevated fasting blood glucose in the range that is typical for this form of diabetes during and after, before, during and after the pregnancy. Again, the increment is relatively small. And as said before, a parent may have mild type 2 diabetes, but often this has not been detected, so the absence of family history should not exclude the diagnosis. We may be dealing with a few combinations of the coexistence of the GCK mutation in a mother and in a fetus. We may have the situation where a mother is a mutation carrier, while the fetus is not carrying the mutation. We may have the situation when both of them are mutation carriers. We may have the situation where neither of them has the mutation. We may have the situation that a mother is not a mutation carrier, but a child inherited the mutation from the father. And what is important, this may influence the birth weight of a child. Quite importantly, as it was said during the previous talk that Gaia provided, we do not have much evidence that the introduction of the pharmaceutical treatment changes in any way the clinical outcomes. For example, you see here the slide showing that essentially the birth weight was not different in groups of mothers the pharmaceutical, in whom the pharmaceutical treatment was introduced, as compared to those that were on diet only. You see that there was no any difference as far as the birth weight of the child was concerned. So I think that we have a few important questions concerning GCK mode as far as the pregnancy is concerned. For example, should we initiate insulin therapy in gestational diabetes due to GCK gene mutation, not having any solid evidence in the hand that it makes any difference? If yes, however, what insulin doses are recommended, taking into account a weak effectiveness of this treatment? What is the role of a dietary treatment? Should we be doing prenatal testing for GCK mutations? As I said, I do not have clinical scientific data to answer these questions. What I may do is to share my own experience and the way we are acting. We do initiate insulin therapy in GCK mutation carriers because we need to follow our guidelines. And the guidelines say that, pharmacotherapy should be introduced if we are not reaching the glycemic goals during the pregnancy. However, we are trying not to escalate the doses of insulin. I have to say that we have a case of GCK mutation carrier patient with diabetes where the insulin dose was escalated and it reached more than 100 units. We cut this by more than a half with no substantial impact on the glycemic control. What is the role of dietary treatment? We consider this to be a very important factor, and I think that this is the only effective treatment we really have, particularly as far as the postprandial glycemia is controlled. And should we be doing prenatal testing for GCK mutations? Definitely not. Not for the purpose of finding the GCK modi only. However, we may use this opportunity and test for GCK modi, for example, when doing prenatal testing for any other reason, for example, when the age of the mother is the indication. Now I am moving to the guidelines concerning HNF1 alpha mutations. So this is young onset diabetes, usually the second, the third decade, non-insulin dependent outside the normal honeymoon period, and almost always family history of diabetes is present, frequently in 2, but also in 3 and more generations. This may be insulin treated and consider again to be type 1 diabetes in parentheses or type 2 diabetes. And usually when you see the family, at least 2 individuals within the family would typically be diagnosed in their 20s and 30s. And you need to realize that such a simple clinical test as OGTT may be extremely useful, helpful to make the initial differential diagnosis between GCK modi and HNF1 alpha modi. Because, as it was said, in GCK modi, you have slightly elevated fasting glucose level. However, the increment is not huge. While in HNF1 alpha modi, the fasting glucose level may be essentially normal. However, the increment is much larger than in GCK modi. The other typical clinical characteristics of HNF1 alpha modi patients include the absence of pancreatic islet autoantibodies, glycosuria at blood levels below 10 millimoles. I think it is important to remember about that. There were reports from several countries on this issue. From Germany, this was the first one actually by Stefan Menzel, then the reports from the UK and also from this country. For example, I hardly believed that glycosuria may be present before diabetes is diagnosed, before OGTT is pathological. But we truly saw such patients recently in the clinical practice. So glycosuria is an important and typical clinical feature. Marked sensitivity to sulfonylureas and other features suggesting monogenic diabetes rather than a diagnosis of early onset type 2. No marked obesity or evidence of insulin resistance, absence of acanthosis nigricans, and early onset in at least one family member. And this is a slide once again to emphasize the issue of glycosuria in HNF1 alpha patients. Remember that this gene is expressed not only in pancreas but also in liver and kidneys, and that's why this clinical symptom occurs. And again, I would like you to realize that we should consider, we should remember that HNF1 alpha gene mutations may be a cause of gestational diabetes. We should ask pregnant women about their family history of diabetes. I am showing a picture of one of our patients who developed gestational diabetes in 60s. And in this, and it was diagnosed too late, and it resulted in the brain damage of one of her daughters. And had he been asked about the family history, this could have been diagnosed much earlier. In her family, every second person on one side has diabetes. So remember, always ask about the family history, because this is a key factor in the clinical practice. And now some indications for HNF4 alpha mutation testing. This is considerably less common than HNF1 alpha gene as a cause of MODY. The clinical characteristics are quite similar to HNF1 alpha, except of no low renal threshold. And HNF4 alpha mutations should be considered when HNF1 alpha analysis does not detect a mutation, but the clinical features are strongly suggestive of HNF1 alpha. Additional features include, as it was said, macrosomia and transient neonatal hypoglycemia. The possibility of HNF4 alpha mutations should be considered when diabetic family members have marked macrosomia, or if diazoxide-responsive neonatal hyperinsulinism has been diagnosed in the context of familial diabetes. There are also some more rare forms of MODY. I think that probably the most frequent of them is HNF1 beta MODY, with the typical renal phenotypes such as renal agenesia or renal cysts. Also, pancreatic hypoplasia was described in HNF1 beta mutation carriers. I mentioned that there were a few, I would say, MODY-like syndromes reported over recent decades. One of them, a very interesting one, is a syndrome associated with cholesterol esterase lipase gene mutations that causes autosomal dominant diabetes and exocrine pancreatic insufficiency. So far, it was reported only from Norwegian population.